Yeah. Good morning. Welcome. Thank you, everybody, for coming to Primary Children's Pediatric Grand Rounds. I'm Miguel Canaco, one of your hospitalists and course director. Today's Cloud CME claim credit code is 52520. 52520 for everybody to claim. The online questions go in the live chat, and for people in the auditorium, just raise their hands and the speaker will call on you. Would you please nominate safety heroes for safety hero awards when you see someone using error prevention technique? Today, I just want to encourage a diagnostic pause. I was thinking about dermatology related. We are so good at pattern recognition, but to always pause and think of what else could this be? And, measles, Kawasaki disease, and adenovirus can look a lot alike depending on what stage they're in. So just a diagnostic pause of what else could this be? And we deal with that all the time in hospitalist work. Okay, now to introduce our speaker. So Dr. Luke Johnson practices and teaches both adult and pediatric dermatology at University of Utah. He also co-hosts a podcast about dermatology called Dermosphere. I listen to it. They review articles, like really conversational style and entertaining, and they get practical about what to do in clinic for it, like how to get the big OBGYN swab and twirl it out to make the very, very best liquid nitrogen dispenser that you can really titrate that liquid nitrogen on. And in his free time, Luke enjoys the board games, long walks on the beach, and he has a minoxidil distillery in his house, which you'll see worked out great for him. Is way too late for me. So, Dr. Luke Johnson.
Hi guys, good morning. It's nice to be here. Thank you for the invitation. I'm with the Pediatric Dermatology Division here. I see adults as well out in our satellite clinic in Murray. I find that most people around here know my colleague Dr. Sarah Cipriano a bit better than me, but we've been here for about the same length of time. I started back in 2018. I think I just keep a low profile. Our division also includes Dr. Amy Theos and Dr. Shaddai Gochiman now, so you'll see a number of pediatric dermatologists wandering about if you could use our services. So, wondered about what to talk about today. It's been a while since I've done like inpatient pediatrics, like since back in medical school, so I have a limited ability to remember the sorts of things that inpatient pediatricians know and what they don't know, so hopefully we sort of got it right. As far as disclosures, there's this business, and our objectives are to talk about dermatologic urgencies and emergencies. Not exactly an oxymoron, but certainly not as many emergencies and urgencies in our world as in some of yours. And then there are also a few oddballs thrown in here, stuff I didn't really know about until fellowship, but are actually like not that uncommon, and I think useful for an outpatient pediatrician, for example, to be aware of. This is the podcast that Miguel mentioned. Thanks for bringing it up. It's a dermatology podcast by dermatologists for dermatologists and for the dermatologically curious. So if you want to listen, then please do. We do have a couple educational grants that we've received from these two companies, and then our listeners can also contribute. All right, let's get started. So our first case, this 5-year-old boy who shows up in the ED. He's had some fever for almost a week. He doesn't feel good. He's got a cough. He's got a sore throat. And then his parents say he's much worse today. Got these new skin lesions. He's been taking these medicines since this started to try to make him better, but he's just not really in a good place. You can tell these are not all the same person. These are representative images. So what is this? This is Stevens-Johnson syndrome. I figured I should start with SJS, otherwise you guys would all be sitting there thinking, one of these has got to be SJS. When's SJS going to come up? We want Stevens-Johnson syndrome. And here we are. So this is a severe acute illness. You got a lot of mucosal involvement, so by definition you need at least 2 mucosal sites, and then you have some skin involvement too. Usually, like in this case, there's a prodrome, fever, malaise, headache, etc. And then you get these skin and mucus findings a little time later. This is me about 15 years ago. My hair was darker then. You guys can let me know if I should bring back the chin beard. I'm at a family wedding with my uncle, Steven Johnson. Uncle Steve's a pretty nice guy. He's a former corporate lawyer, so some former corporate lawyers make you feel like you want to tear your skin off, so it helps me remember the name. This is one of my patients from here in this hospital. Maybe 6 years ago, family gave me permission to use this picture. So he started off actually not looking too bad. He's got fairly extensive skin involvement in this picture, but when it started, he just had a few dots on his face, on his arms. His mucosal involvement is there, but it's not all that impressive. So sometimes this can hit you in the face, sometimes it's a lot more subtle. There's a close up version. We'll talk a little bit more about SJS in a second, but we're going to talk about another case. This is a 13-year-old girl who, over 4 days, developed cough, headache, mild fever, sore throat, mild rash on the face, and then spreading rash and skin tenderness brought her to the ED. This is another one of my patients. I was consulted on this patient after starting here as an attending like a week earlier. What is this? Yeah, this is like the bad version of SJS, toxic epidermal necrolysis. So very similar to SJS in a way, in that it involves your skin dying and peeling away, and you also have mucosal involvement. The difference is this one's a bit more acute, and it's also worse. They are just sicker overall, they have more skin involvement, and there are more sequelae. So how do you figure out which is which? Some people like to lump them these days and just call this all necrolytic epidermatitis and such names, but we're still mostly using this old school delineation here, so it depends on how much of your skin is affected. So if it's 10% or less, that's SJS. 10% or less is not really all that much. So I think most of our patients that we refer to as having SJS actually probably have the SJS-TN overlap syndrome where they just have TEN. And the more skin involvement, the worse your prognosis. So drugs are typically considered the most likely causative agent, especially in adults. And usually you were exposed to the drug 1 to 3 weeks prior. This 1 to 3 weeks thing comes up repeatedly in dermatology when we're talking about cutaneous drug reactions. So morbilliform drug reaction tends to show up the similar length of time. Dress is kind of an outlier. That one takes longer, but in general, 1 to 3 weeks sounds right. So it could be something they don't remember having taken because it was a while ago, and then the amoxicillin they just started yesterday is really unlikely to be the culprit. And then in kids, we get SJS from infections a fair amount. And there's lots of times when we can't find an infection, so we assume that it must be an infection just because there's nothing else that could really trigger the presentation. Pretty much every drug, licit or otherwise, has at least one case report describing it's associated with SJS or TEN. The same is true of vaccines. So you can never really be out of the woods, but here are a few that are just a little more likely than others. So what do you do? Well, obviously, you do all this good stuff. The medication history is particularly important. You want to check some labs because there can be organ derangement. And then you mentioned Rhyme earlier. We'll talk about that one shortly, but Rhyme can look like SJS, so that's to make sure that you're not missing that. How bad are your chances? Well, there's the score 10 syndrome that was developed like in the 80s that purported to show you how likely you were to die, depending on all of these parameters when you came into the ED and into the hospital. It was validated in adults, and then this 2017 study also showed that it did a pretty good job in kids. The good news is that the score 10 currently overestimates mortality because our technology has advanced and we're better at keeping people alive and then making them better and getting out of the hospital. But it still can give you kind of a relative idea of how bad people are. So what do? You stop the drug if you can find one for sure. There's plenty of studies that say stopping it early gives you a better chance. There's some thought that it's the toxic metabolites that have built up that could be the problem. So drugs with longer half-lives, they and their metabolites stay in your system longer and you're not in as good shape. And of course, we need our intensive supportive care burn center, which we've got access to, especially if they've got more than about 10% skin involvement. A lot of people get involved. There's all these mucosal sites. There's the skin. So you want to probably consult most of these people. The psychiatry mental health thing has been getting increasing attention lately, including after people leave the hospital. a lot of them still have, psychiatric issues that would benefit from being dealt with, assuming we have the person power to do so. In terms of actual treatment, there's a few options. So, cyclosporin is one that we often use, and it's mostly because of this study here. So, I don't know if any of you guys have ever been to Madrid. I haven't, but if I did, I probably would not drive from one hospital to another. I would have better things to do. But in Madrid, there are these two hospitals, kind of on opposite sides of the city, and they just both had different protocols for treating their patients with SJS-TEN. One used cyclosporin, the other used old school glucocorticoids. And it turns out that patients in the cyclosporin hospital just did way better. And that was published, and this is sort of a natural experiment. And so we're kind of out on prednisone for TEN, still okay for the mild SJS versions, and much more in favor of cyclosporin. And then the other one we tend to use around here is a etanercept, which is due to studies like this one that have shown pretty dramatic results, but are mostly in the case series realm still. So we have a protocol here, and thanks to Dr. Sarah Cipriano for coming up with it. So this is something we have access to in our dermatology Pulse site. I'm sure you guys could access it too if you know how to get into Pulse. Um, but this is what we do if you were to consult us. Depends how bad it is, and then we can consider these treatment options. You can see etanercept doesn't really have a lot of contraindications. I feel like we should use it more. By the way, feel free to ask questions as we go here. Happy to chat about this or anything dermatology or anything board game related. Just let me know. Next up, there's a 12-year-old boy in the emergency room with cough fever, conjunctival injection, sores around the mouth. He's got a fever. His pulse ox is 88%. I guess that's low. Lung crackles. That's what a chest x-ray looks like in a patient like this. I'm told that's not normal. And then here are some representative photos. What's this? This is rhyme, yes. And there's the source. So reactive infectious mucocutaneous eruption, kind of like SJS and the fact that it affects mucosal surfaces, but it's not nearly as bad. And the fact that Rime exists has really complicated dermatology literature in this space for like 100 years because people used to think SJS and Rime were the same thing. It was only about 15 years ago that we realized they're actually different entities. And so anything published before about the year 2000 or 2010 is suspicious if it involves SJS. People usually do pretty good. You, I'm sure, have seen these cases. It's like rhyme season now because it's cold and flu season. So we've had plenty of these patients in the hospital recently. And they're pretty unhappy for the most part when they're here, but we can give them steroids. You can give them etanercept if you want. We do magic mouthwashes and clobetasol ointment on their lips and so on and so forth. And then they get better within 3 to 8 days on average, I guess I would say. And then they pretty much go home and they're pretty much fine. Mycoplasma is still a pretty common cause, so we used to think this was due solely to mycoplasma and it had a different name, MIRM, mycoplasma induced rash and mucositis, but we've since discovered that it can occur with lots of different infections, primarily respiratory infections. So now it's called Lyme. COVID can cause it too, but check for mycoplasma. And if it's there, treat it. Some more representative pictures. Any questions about rhyme? Okay, our next case is a 9-month-old girl who has been acting punky for a couple days with fever, poor appetite, and decreased energy, and this morning her skin started to fall off. This is a hint as to what's going on. Any guesses just based on the hint? Yeah, you got it. So here she is. So sometimes when giving these dermatology talks, it's nice to practice our dermatologic lexicon because we love our words in the world of dermatology, patches and plaques and macules and things. So I won't make anybody say it out loud, but think to yourself how you might describe something like this. This patient has a diffuse erythematous rash. You could say an erythematous patch if you wanted. With xerosis, we say xerosis instead of dryness, so we sound smart. And then you can see this peeling in areas. So staph scalded skin syndrome is caused by staph. which is somewhere in the body, but usually not in the places where you see the rash. It's somewhere else, and it's a particular type of staph that excretes these toxins that go into your blood and travel all around your body and get into the skin and cause it to fall off, or at least the very top layer to fall off. So you don't have to, but sometimes it's nice to find this nidus of infection. So oftentimes I discover that kids have like gloopy eyes or gloopy noses, and that's probably where it comes. Especially in infants and toddlers, you can get the perianal staph, you can get perivulvar, the same thing as well. So sometimes that's where it starts. Plenty of times we never find it in patients who are otherwise kind of ill. We found it like staph abscesses in their psoas muscles and things, but that's uncommon. Normally, these patients are otherwise pretty healthy, and it's just kind of bad luck. Contrast to SJS-TEN, so there's no mucosal involvement. Oftentimes, their lips are pretty chapped, like this guy, this baby. They're just like unhappy because this doesn't feel good, and they're often kind of breathing through their mouths, but there's no true mucositis. The cleavage is through the layer of the stratum corneum. My colleague, Dr. Sarah Cipriano, again, refers to herself as a staph scalded skin nerd and has investigated this condition and has published on the fact that blood cultures, for example, are unnecessary. These kids just don't need a lot of workup. It's fairly clinically obvious most of the time as to what it is, and then you can initiate treatment without having to poke them a lot. And especially when it comes to culture, sometimes they came back with contaminants and then they get put on additional antibiotics, and it's just medical waste and potentially a risk to the kids. Okay, so I mentioned the stratum corneum. Oh, look, I have a pointer. Okay, so this is the sort of thing we look at when we're in dermatology residency. It's a photomicrograph of the skin stained with hematoxylin and eosin, H and E, and this is a diagram of the same thing. So we're all going to become early dermatopathologists right now. So the very top part of the skin is called the epidermis. It's very thin. Look, it's just this very purple part here. And then the part underneath is the dermis. Look how much thicker it is. This is quite variable depending on the anatomic site. One reason why skin is so awesome, it's so different in different parts of the body. You can tell there's hair here. So this is some place that has hair because here's a big old hair shaft, and this right here is a hair shaft coming this way, but it's sort of cut in cross section so you can't see the whole thing. But this is not the eyelid, for example, which would have like no dermis. It's probably not the back because you wouldn't have these terminal hairs. So it's probably like the scalp or the face or maybe the leg or the arm where you get some hairs too. And then underneath the dermis is fat and stuff here, which we call the subcutaneous tissue. As you can see, the dermis is where a lot of action is. There's glands and muscles and blood vessels and things. And the job of the epidermis is mostly to protect the skin and keep water in, keep bad stuff out, and then there's a lot of other stuff going on at the microcellular level. So when we said this cleavage is through the stratum corneum, that's the very top layer. You can barely even see it here. It's this pale stuff here. We sometimes say basket weave to describe it. And these are the ghosts of dead keratinocytes that have transited from the bottom all the way up to the top, living fruitful lives as they do so, and then the husked, zombified versions of themselves protect the skin in their final days before they are shed. And that's where the split from staph scalded skin comes in. And that's helpful because you can differentiate it from conditions like TEN and SJS. In those conditions, the whole epidermis dies and peels away. So it's all of this purple stuff that goes away and goes bleh, and then underneath it you can see dermis. Staph scalded skin, superficial, so underneath is just more epidermis. So here are two of the patients that we've already seen today. And I recognize that as a dermatologist, I've been looking at skin for a long time, so it's probably not as obvious to people who don't do stuff like that. But to a dermatologist's eye, the difference is fairly striking. And I'm belaboring this because I'm hoping to impart some of that to you all as well. So this is very thin, and underneath this is more epidermis. It's just not as protected, so it looks a little bit moist. But then the stuff peeling away here is thick. It looks like my kid's toilet after they fail to flush properly. There's all of this toilet paper wadded up stuff being pushed off to the side, and underneath it is this pink moist dermis that looks like it would be uncomfortable if you were to like even blow on it. Whereas this looks like it wouldn't be that bad. So significant difference. Sometimes we get consults from usually not here because you guys are pretty up on it, but some outside hospitals that are like, is this staph scalded skin or TEN? And a good eye can sometimes make the difference. Okay, our next patient is 15 months old. Fever, worsening rash. This is kind of the theme of dermatologic urgencies and emergencies. You look at his chart and you find that he has seen Dr. Johnson in dermatology and has atopic dermatitis. I'm always disappointed when my patients come into the emergency room. He does have a fever, he's drooling, doesn't really feel great. This is what you find on exam. Thoughts? Before we ever land on a diagnosis, we can consider using our dermatologic lexicon skills. So these are scabs, but again, scabs doesn't sound as cool as hemorrhagic crusting. So hemorrhagic crusted circular papules, you could feel those. They're not macules, so things that you could feel and are smaller than a centimeter is a papule. They're punched out, I think is an appropriate word. It looks like you could have punched those out with little tiny cookie cutters. Some of them are clustered. There's kind of this background of erythema. You know he's got eczema. That's it. Eczema herpeticum. I heard it. So if you've got eczema, then your skin barrier is compromised and stuff can rapidly get in there and cause a problem. Bacteria do it, so eczema frequently becomes impetiginized, and viruses can do it, so the herpes virus is notorious for doing this kind of thing. Kids who've had atopic dermatitis that's just not well controlled, as you might guess, they're the ones with the worst skin barrier, and so the HSV can go crazy. But I've seen this at least a handful of times in kids who normally are doing pretty good, but then this just blows up almost out of nowhere. So there's a certain amount of just bad luck to it, I presume. There are other viruses that can do this as well. Coxsackie is the one that we see the most commonly that's not eczema herpeticum, so hand, foot, and mouth can also just get everywhere. It looks kind of similar. We call it eczema coxsackium. And then hypothetically, varicella or vaccinia could do it too, but we almost never see that. This poor kid on the bottom, you can see also has this yellow crust around the mouth, so probably impetiginized in addition to eczema herpeticum, which is pretty common. It can be pretty bad. We've seen it in like 3 months old who are in the hospital for a couple weeks getting their acyclovir. And I've also seen just a single vesicle on some kid's wrist and you swab it in HSV, but they just treat as an outpatient because otherwise they're fine. Still, it can be bad and it tends to affect little kids because eczema tends to be worse in little kids. So you want to be cautious. There is a risk that it could get real bad if somehow this gets missed. And mentioned the secondary bacterial infection is common, so you want to treat that as well. What do you do if you've got a patient like this? Well, if it's near the eye, HSV can get in the eye, so ophtho should perhaps be involved. Some of them need to be admitted for these issues, some of them don't. HSV PCR is definitely the best test. Do not order a viral culture. It probably exists in the system just for the rare cases where you can find some kind of resistance to your valacyclovir or acyclovir. But if you're just trying to see if somebody's got HSV, just swab it for HSV PCR. It's very sensitive and specific and comes back quickly. If you feel like getting a bacterial culture, I would not fault you. If you don't feel like it, I would not fault you for that either. Just put the patient on cephalexin and they'll probably be fine. Systemic acyclovir tends to be what we use. Valacyclovir could be used, but the dosing is not as well described for kiddos. Question?
If it's so widespread on them, do you have to be careful, like choosing your IV site for a place that's not involved?
I have no idea. I don't usually put in IVs, but seems like sticking your IV through HSV is probably a bad move. So try to find one that's better. In terms of what to do about the eczema that's underneath, there doesn't seem to be agreement in the world of pediatric dermatology. A lot of my colleagues say wait until all the lesions are crusted over before initiating topical steroids. For that, it's okay to put Vaseline, for example, which is our favorite moisturizer on the area. But there's some literature, including from the ophthalmology literature that we discussed on the podcast, that says that antivirals and steroids can have a synergistic effect. So I'm kind of in favor of just smearing them up with triamcinolone 0.1% ointment as soon as they get through the door. And hopefully you're treating two things at once. Any other questions about eczema herpeticum? Okay, another hospital case. So this is an 8-year-old boy. He's had a rash on the palms for one day. That's what it looks like. His lips are kind of crusty, another common theme today. He had a recent cold sore outbreak. Maybe not quite a fever, but not normal. And again, we can think about how to describe this from a dermatologic standpoint. Circular erythematous edematous thin papules, perhaps, was what was going through your heads. Some more representative pictures. Targetoid, that's right. What is this? Bye, guys. Thanks for coming. This is erythema multiforme. I think I heard somebody mention it. So this one's not as bad as most of the rest of the stuff we discussed in most cases, though you can have a lot of mucosal involvement occasionally. This one goes away on its own. It usually is from HSV. So sometimes they have an outbreak and you can swab something. Sometimes they didn't have anything visible, but it's presumed from HSV. Every so often it can be from something else. You get this typical target, like you can see diagrammed down here. It's got a papule vesicular bullet in the middle, and then 3 different zones total. So you can see bullseye, and then kind of blank, and then another rim of something. This is to contrast it with an atypical target, which has only 2 zones of different colors, which you see more commonly in SJS and TEN. This is usually acral. Palms and soles are commonly affected. Tends to be kind of symmetric. What movie is this from? Men in Tights. It's a great movie. So this tends not to just feel that bad. Mostly kids come into the hospital or to the emergency room or to their pediatrician, mostly because of the mucosal involvement or just because the rash looks dramatic. Doesn't feel too bad though. And to contrast it with something like urticaria, the lesions sit there and are fixed for at least a week, whereas in urticaria they go away or they're evanescent within 24 hours. Oral lesions fairly common, just continues for 2 to 4 weeks. There used to be some concern that this could progress to something worse. They called it the EM/SJS spectrum, but that is currently now thought not to happen. We'll see if we change our minds in another 20 years. How to treat it? Well, it's going to go away on its own. So mostly it's getting people comfortable until it goes away, and then perhaps treating their herpes infection if they have one. So antihistamines are fine. In my personal opinion, they're just overused in the medical system because that's not most, at least some itch that our patients experience is not histamine driven. So it doesn't really make sense that antihistamines work. But they're safe and sometimes make people sleepy, which is desirable. So I suppose that's fine. We always smear people up with topical steroids in our world, of course. And if they're uncomfortable, then of course, give them NSAIDs and acetaminophen and so forth. You have occasional patients where this is a recurrent issue, and so you can consider suppressive acyclovir or valacyclovir for them. Questions on this one? That's the end of the inpatient portion of the evening. Let me have a drink here, and we can talk about a few oddballs that are more like outpatient presentations. All right. Now we have a white background because it's happier. We're not in the black, dark, dismal hospital. No offense to you guys who are hospital workers. We're out in the sunlight. There's windows in our clinics. So there's 3 conditions here that I didn't really know about until fellowship, but I should have known about a lot earlier probably, just again because they're like not that uncommon in our pediatric patients. So again, we'll present them with cases. So our first case is a 5-year-old boy. He's had intermittent pink bumps, not a dermatologist writing this, of course, on the extremities and trunk for 7 months. They've been coming and going. Parents got some hydrocortisone 2.5% cream from an outside provider, and that helps a little bit, but the bumps just keep coming back. Patient's otherwise perfectly healthy guy. No one else in the family is affected. They have a dog named Roscoe. Roscoe undergoes regular flea treatments. They used to have a cat, but they started worried that the cat was the problem, so they got rid of the cat. This is a theme I see sometimes. The dog stays, but the cat goes. What's the deal? Do we not like cats? Erythematous edematous papules. Any thoughts? Papular urticaria is a good thought. In fact, that's what it is. These also just look like bug bites, right? And that's really what papular urticaria is. It's not a good name, though. It is papular, but it's not really urticarial, so it probably should have a different name, like recurrent arthropod reaction or insect bite hyperreactivity. So, the way I explain this to families is that in some ways, little kids are like allergic to bug bites because their immune systems are still developing. So, weird things can happen when they get bitten by a bug. They can get bit here, but it's some old bite over here that lights up for some reason. They can get bit, but they don't actually show the reaction for a couple weeks afterward. It's just funny. And it's by definition a hyperreactivity, so it's fairly common for only one person in the household to be affected, even though hypothetically, whatever bugs are around are probably biting everybody they can get their little teeth into. And also, kids just tend to make more exuberant reaction to bug bites because their immune system hasn't been, as inured to the insult. The three most common types of bugs that can cause the reaction in this country are pictured here. What's that up there on your top left? It's a flea, and next to him, and then down below, bed bug. Yep. So my favorite article about this condition is this one here. It's kind of old now, but an oldie but a goodie, as most of us are. And in this article, they talk about what they call the scratch principles, which are a lot of fun and I think worth going over. So these are characteristics of papular urticaria. So S stands for symmetric distribution. C is crops or clusters, like you would normally find in bug bites. R is one of my favorites, rover not required. You don't have to have a pet because these are the bugs that do it. There's only one of them that likes to live on animals. But still, if they do have a dog, it's a little bit suspicious. The A is for age, so it's usually elementary school to little kids, age 2 to 10. T is for target lesions. They look a little bit like targets. And time. It just takes a long time, both for individual lesions to resolve and for the whole condition to go away. But kids do basically grow out of it. My favorite of them all is the letter C, confused pediatrician or parent. We don't have fleas, they say. Nobody else is being bitten. So the fact that they don't believe you means you're right. Isn't that the best? I wish all of our conditions had that. And then again, only a single person needs to be affected. So again, you don't need to have a dog. So what do you do? Um, this is my approach. So insect bite reactions are histaminergic. So antihistamines are really an important part of the treatment. And again, they're very safe. So non-sedating, and you can use a lot of antihistamines. And our chronic urticaria patients guidelines say start, well, you don't have to start, but you can go up to 4 times the normal dose with no problems at all. And that's been shown to be safe in children as well. So our allergy colleagues, for example, for their chronic urticaria patients will do 2-fexofenadine in the morning and 2-cetirizine at night, for example. I usually start strong and then taper back if the patient is responding well rather than slowly going up, just again because they're so safe. Topical steroids, triamcinolone is our workhorse for sure. They can just use those a couple times a day for these bug bite things and they'll go away. Sometimes you got to find the source. So if they do have pets, I recommend the pet be taken to a veterinarian. They're not always itchy if they have fleas. They can seem like they're fine. Sometimes you got to be looking for bed bugs, but sometimes it's fleas from the dog that lives 2 houses away, or it's mosquitoes that are flying around in the summertime and you just can't do anything about that. So I just tell parents, all we can do is our due diligence. Look at your bedding, make sure there's no bed bugs, get the dogs checked, and if you've done that and it's still happening, you've done all you can. It's uncommon that they get secondarily infected, but if kids are scratching the heck out of them, they could be. So sometimes it's nice, potentially helpful, and the parents feel better if you prescribe them a little mupirocin, for example. This is a bed bug that I caught with a pair of forceps. It was left on an exam table after my patient walked out of the room. I was very proud of myself, and I'm still showing it 10 years later. As we've discussed, the time from bite to reaction is variable, and the older you are, the longer it takes. We talked a little bit about these as well. questions about papular urticaria? Yeah.
Antihistamines and stuff.
Yes, for sure. So the most common cause of urticaria in children is a viral condition, just a URI usually, and I routinely recommend those high doses of antihistamines. What's the second most common cause of urticaria in children? Idiopathic. And the most common cause in adults is medications. Okay, our next case is a 4-year-old girl. Again, you see that she's seen Dr. Johnson for atopic dermatitis. Keep coming back. But they've been doing all right, using hydrocortisone 2.5% ointment, some triamcinolone. Eczema generally seems pretty good, except more recently she's developed these recalcitrant itchy plaques on the bilateral thighs and buttocks. Like that. What's the deal? The rest of her looks fine. Thoughts about this one? I'm assuming that those of you who are attending remotely are also thinking about this to yourselves. I thought this diagnosis was a joke the first time I heard it, but this is toilet seat dermatitis. We have all these funny names in medicine, like a rectal trumpet or a pulmonary toilet. This isn't as bad as those. It is, in fact, dermatitis to a toilet seat. So usually it's a reaction to the cleansers used to clean toilet seats. People can sometimes use these harsh bleach-based chemicals, etc., and then these kids often have sort of an eczematous tendency or sensitive skin, and then they react to that. Oftentimes these are kids that are potty training, so they sit on the toilet for like a long time, especially if they're like my son was when he was potty training. He was on there for like an hour, like wiggling around, getting sweaty, looking at a book, looking at an iPad, like taking pictures, hopefully not too many like this. Finally, he got potty trained, and I wish that for all of the parents out there. But you can see it in other kids too, but the longer you spend on the toilet, the more likely it is, kind of the more sensitive your skin is, the more likely it is, and the harsher the detergents used, the more likely it is. You can get an allergic contact dermatitis, but that's much less common. It's because the materials that toilet seats are made out of these days, this white porcelain stuff, is just not very reactive. But occasionally, people with like old school or fancy toilets that are like lacquered wood, they can get the allergic contact dermatitis version. And it shows up in the spots where your thighs contact the toilet. So what do you do? Well, I must have had a premonition of this when I was in my 20s because my solution at that age was just to never wash my toilets. Most of my parents are not really excited about that plan, though. So sometimes it can be as simple as just rinsing the toilet seats with water after you clean them. You could use toilet seat protectors. This is one time when I think they actually have some medical advantages, especially if this is like a significant problem and at school and in other public places, you can't decide how they clean their toilets. And they also usually use like this industrial strength acids, I presume, to clean their toilets. So, especially if they're there and they don't have to like bring them in their backpack, that could be a reasonable thing to do. You could use gentle cleansers to clean the toilet seats instead, like a water and vinegar mix instead of the Lysol or OxyClean you can get. And then otherwise, you just treat it like an irritant contact dermatitis with topical steroids and emollients. If you are worried that this is an allergic contact dermatitis, then patch testing is our protocol to determine what you're allergic to. Questions about toilet seat dermatitis? Okay, we got one more. A 2-year-old girl in the emergency room. 5 days ago, she went to her PCP. Seemed like she may have had a URI, maybe some ear stuff going on, got amoxicillin. And then 2 days ago, she got this fairly dramatic rash that makes her parents concerned. Plus, she doesn't really want to walk around, so that has them concerned. She's not feeling great, but she's not febrile. This is her. This is one of my patients. So we can think about how we would describe this using our dermatologic language. Erythematous plaques. Maybe use the word arcuate or confluent. You can see there's different morphologies. Some sort of dark ecchymotic looking areas. Thoughts?
Serum sickness reaction.
Serum sickness-like reaction is a real good guess. This can look like serum sickness-like reaction, but this is urticaria multiforme. This is one of my favorite diagnoses. I like the diagnoses that make me seem smart, and I find that this one makes me seem smart for some reason. It's like super urticaria. So the way I describe it is urticaria gets swollen because the blood vessels get a little bit leaky when you have urticaria, and so some serum leaks out and they get a little raised. In urticaria multiforme, the vessels get really leaky, so some red blood cells leak out, and that leaves you with this bruise-like appearance. Just like normal urticaria, this is usually from a viral illness. It's usually not from the amoxicillin that they took, but a surprising number of them have taken it recently. It can lead to joint effusions, and especially since this affects little kids, they can't properly communicate. I just feel stiff and uncomfortable. It's not like they hurt, and so they don't feel like they want to walk around, and that can be mistaken for true arthritis. So this is my favorite article here. Again, a little bit of an oldie but a goodie. And these are some of the clinical features associated with it. So they're almost always itchy. You can see that pruritus is such a funny word that even published dermatologists cannot spell it correctly. It ends with a US, not an IS. This angioedema business is fairly common as well. And then oftentimes, 2/3 of the time, they had a recent illness of some kind. You can see that recent antibiotic use is also pretty common. And then fever is also fairly common, but less than half. These authors propose some diagnostic criteria. I'm not going to hit them all, but I highlighted the ones that I thought were the most useful. So this annular and polycyclic appearance, these ecchymotic skin changes are highly characteristic. They don't have true targets. They don't have necrosis or blistering. They don't feel great because they're not feeling like walking around and they had a viral illness, but they're not like sick like TEN patients are. And they don't have mucosal involvement. So no true arthralgias or arthritis is important. So what do you do? So again, antihistamine is really good because this is like super urticaria, so you need super antihistamines. So again, our 4 times dosing. Systemic steroids are reasonable if kids are like really unhappy. We do it maybe 40% of the time, I would say, when we see one of these patients. There's research that says even a short, like 5-day course of steroids does increase the risk of conditions like pneumonia and sepsis in kids. Of course, that risk is already so small that even if you double it, it's still really small, but it's just a reminder for us to be cautious with our medicines. This was not an allergy to the amoxicillin they took 3 days ago, so that doesn't need to be placed on the allergy list, but oftentimes parents are pretty worried about it. We have a great allergy division within our Department of Dermatology. So I often will tell these families, if you want, once this adventure is behind you, you could connect with our allergy division and they could do some testing to see if you're really allergic to the amoxicillin after all. And I'm sure you guys know that what they do in the allergy clinic is give them some amoxicillin and see what happens. And they have the crash carts and everything there in case something bad does happen. But it almost never does. This is a disease of little kids, so babies and toddlers, preschool age. Maybe it lasts around 10 days, and then, sort of as you mentioned, serum sickness-like reaction, and then sometimes EM are the main other options on the differential here. It's another one of my patients. So that article I mentioned has this nice table that includes urticaria multiforme, erythema multiforme, and serum sickness-like reaction. And I've highlighted some of the issues that I think are especially helpful differentiators. So urticaria multiforme, usually kids are not febrile, whereas in serum sickness-like reaction, they almost always are. My senior mentor in fellowship said, if there's no fever, it's not serum sickness-like reaction. I have shortened his advice to just, it's not serum sickness-like reaction. Because like 90% of the time when we get consulted on serum sickness-like reaction, it turns out to be urticaria multiforme. I have seen serum sickness-like reaction maybe twice. I've seen this, 20 or 30 times. It's just way more common. Associated symptoms here, you can see that UM has pruritus, whereas that's not really a common feature of these other conditions. And then dermatographism. You guys remember what dermatographism is? You scratch the skin, you can make a line, like a little urticarial linear plaque. And that's a common feature in urticaria multiforme and something that I always check by scratching the kid's back with either my fingernail or with the stick end of a cotton tip applicator. If they have dermatographism, it supports the diagnosis, but it certainly doesn't prove it. Like 5% of the population is just dermatographic, but still, it's kind of a nice thing to do. And then I just have another example of one of my patients who had this condition, 2-year old, whiny, swollen feet, doesn't want to walk sometimes. See, these ecchymotic changes are characteristic. So we put her on prednisolone and hydroxyzine, and 4 days later, this is what she looked like. All cleared up, except for some mild residual pigment changes. And then another one of my patients, a 20-month-old boy. So this is the perfect story. He's 20 months old. He got amoxicillin, probably for an ear infection. There it is, and croup, and he doesn't want to walk. Parents are worried because his hands and his feet and his face are swollen. I really like this picture because it shows the dramatic graphism, but urticaria multiforme does not have to be involved in stealing from your mother's wallet. I don't think I have a before and after picture of him. I just thought his presentation was a pretty good one. You can see how edematous his hands and feet are. And that's all I got. Appreciate the attention. Happy to take questions from the throngs who are here in person or from the people who are watching from home or your clinic space.
Um, thanks for teaching us. What will you can we kind of review which ones? Seems like a lot of those they need their eyes checked, and rhyme they need their eyes checked.
They don't
SJS.
always, but it's a common mucosal site to be affected.
Yeah, which of those ones that we did today where we need the ophthalmologist?
SJS-TEN likes to affect the mucous membranes, and so does Rhyme, and then eczema herpeticum when it's close to the eye. I would get ophtho involved.
Thanks. Other questions today?
Does it get perpetuated by the antibiotic or anything? So we don't know
We
the
don't think
cause
so.
of it.
We think it's just a viral.
Viral?
It's like urticaria, just lots of urticaria. Yeah.
There was a paper that said like 90% of the amoxicillin allergies were coincidental rashes. Do you have an idea of like how much of them were actually urticaria multiforme? Or like do we have an idea of what some of those other rashes are?
Not to my knowledge. Our allergy team might, but people get worried about their medications, justifiably. We saw some of the stuff that they can cause. And so if they develop any kind of rash within 3 weeks of taking a medicine, it's suspicious. And I think we used to have a much lower threshold as a medical community to put penicillin allergy on people's charts than we do now. I think a lot of research now saying that it's detrimental, causes patient harm to label them pen allergic if they're not.
Okay, and we just have a comment online. Very useful case presentations and differential diagnostic points that there are people thanking you for this. So we appreciate you. Thanks for teaching us. The claim credit code is 52520. Thanks again.
All right, thanks for being here, guys.